Well, I appreciate all of you being here, taking your lunch to spend some time talking about some issues that are really important to me and that I think are really important to our state and our hospital system. My name's Carolyn Herrera. I'm a doctoral student at the University of Indianapolis, and I've had the really great pleasure of being able to train in clinical psychology here at the Neurodiagnostic Institute for the last 9-ish months. And it's been really, really sweet and fun and difficult to work in a state hospital system. About around this time last year, when I was onboarding, I remember, well, at least in my interview process, I remember sort of weighing the difficulty of working in a system like this, of this kind of acuity, and really thinking about what mattered most in the kinds of systems of care where I wanted to work, where I wanted to train. And the thing that I loved so much about Indiana state psychiatric facilities is the trauma-informed approach to care. Just that I think that when we have a team-based approach and when our philosophy of care is appropriate and is really focused on best outcomes for patients, then we're able to work in these high acuity settings in a way that is healthy and can be a growing experience. So something that I really love clinically is thinking about work with international populations, specifically refugees and immigrants. So I want to talk today a little bit about how that ties into the trauma-informed care that we care about so deeply in the state psychiatric hospital systems. And I think as healthcare providers, when we start to talk about international populations, specifically in the Midwest, it can be really easy that we start to check out a little bit and go, okay, yes, international populations, trauma, we care, but are these folks that we actually are going to have contact with? Are these folks that we're actually going to see? We value cultural diversity, but maybe it's not part of our experience around here. And as healthcare professionals in Indiana, it's certainly true that we don't see as many folks from international backgrounds as our counterparts, maybe in New York City and Denver and Houston and LA. But refugees, immigrants, and other folks who have come from overseas do make up a substantial portion of our local community. So today I want to talk a little bit about the discrepancy between the proportion of folks who actually come from international demographics and live in our community versus how many we actually see in state psychiatric care. Talk a little bit about some reasons why that may be and see if we can maybe shift some of our approaches to care in order to make it more equitable for folks from overseas. So let's start just by talking a little bit about who our neighbors are. I really wanted to title this slide Hoosier Neighbor, and that was shot down by several people, but nobody said I couldn't say it. So who's your neighbor? Indiana is home to over 28,000 refugees and asylum seekers. The majority of these folks come from Burma and other areas in Southeast Asia. But other prominent population groups include folks from Syria, Somalia, the Democratic Republic of the Congo. Certainly more recently, in the last couple of years, we've seen a massive influx of refugees from the Ukraine, as well as from Latin America. So sort of considering who those folks might look like around us. Indiana is also home to over 350,000 first-generation immigrants, as well as 300,000 second-generation immigrants. So all in all, we know that 11% of Hoosiers are first or second-generation immigrants. In fact, 10% of homes in Indiana speak a language other than English in the home. And when we think about that number, I think that it can be pretty staggering, especially as we start to think about who we actually see in healthcare and specifically in mental health care. Because my experience, and I imagine most of your experiences, might be that when you're interacting with patients, not 1 in 10 of those folks has an immediate international background. Not 1 in 10 of those folks is an English as a second language speaker. And I'd be curious as to why we think that might be. I know there are probably a lot of complex variables playing in, but I'd like to hear your thoughts as to what might be going on there. Yeah.
I think a big piece of it is access to mental health care and how to navigate the mental health system, having resources to be able to do so effectively.
Yeah, 100%. So thinking about like those structural barriers, everything from financial access to transportation, language, all of the things. Yeah. What else might play in? Yeah.
Some of them don't believe in mental health.
Yeah. So stigma, right? Is this a way that my community handles problems? Or do we have other approaches to that? Do we tend to take maybe a more ecological approach? Yeah, is there a question in the chat?
Cultural norms seeking care.
Yeah, absolutely. Who do we find care from? Maybe in my culture, I'm going to pursue help from a religious leader, a community leader, someone like that, and we have a more traditional ecological approach when we're struggling. I think you had an idea as well, is that right? Similar.
Cultural also.
Yeah, sure. So there are a whole lot of different factors that are playing in, right? But overall, the picture that we see is that need for mental health care among folks from international backgrounds is considered equal or greater to that of the native-born population in the States, and yet utilization is significantly lower across subsets of that population. So when we ask international communities about this discrepancy, certainly the things that you guys have mentioned come up, that access barriers and stigma are absolutely huge. And those kinds of things, I think, as providers working maybe in lower levels of system, working in direct care as opposed to more broader system level kind of positions, can seem a little bit out of our reach. But there's some good and bad news, which is that there's also feedback about care at the provider level. And I want to talk a little bit through perspectives on what people see there. Generally, what we see is a lower standard of care in reports from folks from international backgrounds. So they describe a really concerning pattern in terms of relationship, conceptualization, and intervention when it comes to mental illness in U.S. systems. First, in terms of relationships with providers, we see outright discrimination, which obviously can be related directly to distrust in those provider relationships. And we also note a lack of positive or trusting relationships between providers and the actual communities that they serve. When we think about conceptualization, we see that the models of mental illness that are accepted in the US aren't compatible with how folks from other countries think about and understand mental illness and suffering, to the point that even our diagnostic conceptualization is a poor match to their lived experiences. And finally, when we look at intervention, our treatment approaches are described as unhelpful and culturally unacceptable. So when we as providers look at this information, we can see a real breakdown of those trauma-informed care principles that we're committed to. There's not a sense of safety here. There's not a sense of trust. There's a real poverty of collaboration. And all of those things sort of start to fall apart with this population. The overall theme that really emerges in the data here is cultural and structural incompetence, both at provider and system levels, meaning that we as a field are continuing to really, really struggle to understand the interplay between culture and mental health. And this makes sense, right? Working with folks cross-culturally is complicated. Information and specifically good scientific literature on these populations is difficult to access. And obviously providers actually have a lot on their plates without taking on more and more bits of education. There's a responsibility certainly to educate ourselves, and also from a time and burnout and mental capacity perspective, this can be difficult. So I want to talk through today just a general model of how we can understand the relationship between culture and trauma. And then I want to talk about some practical ways that we can implement that in the care that we provide day to day, hopefully just to increase the standard of care for the patients that we serve. So when it comes to trauma and culture, a framework that can be really helpful for us is called just the 4 E's. And it basically outlines how we experience trauma and how we act from and out of that in variable ways based on intersectional cultural identities. So not simply thinking about, oh, this individual is from this country and so it will look this way, but thinking where in a specific country, where in a specific region is an individual from? Is their background rural or urban? What's their gendered or sexual experience? What's their religious background? What other pieces of cultural formation are all going to come together to produce this person's really unique perspective on life and their own unique experience of trauma? So our first theme here is that trauma is embodied. It occurs in the body and in the mind. And that happens in different ways depending on different cultural factors. So some common reactions that we talk about in the US when it comes to trauma in the body, of course, are medical outcomes for those adverse childhood experiences. Maybe with PTSD, we think about trembling, about sweating. And in other cultures, things can look a little bit different. Certainly we see the same pattern in terms of chronic health conditions following adverse childhood experiences. But other common physical complaints that we would see a little bit less frequently in the US might include vascular abnormalities or complaints of pain. And particularly in cultures where stigma is going to be more prominent, which of course is going to be pretty common, those somatic symptoms may make up a majority of an individual's presentation. And this is a point where it can get a little bit complicated in our conceptualization, right? Because we've got this tendency or this temptation to say, oh, this patient is somaticizing. These symptoms are because they're not able to express it in another way, which really isn't compatible with the way that we understand trauma as being embodied. That rather than that being an expression of what's going on in the mind, that it truly is an expression of what is actually happening in the body as well. That the body is experiencing symptoms of distress on its very own. Secondly, trauma is embedded. It occurs in a social context. And this is especially important to consider when we're talking about collectivistic cultures, right? So brief little overview for us, little reminder of individualistic versus collectivistic cultures. Folks from individualistic cultures, typically Western cultures, tend to think of themselves in terms of course, the individual, in terms of one unit, whereas folks from collectivistic backgrounds tend to think of themselves as parts of a whole. I had a really great interaction around this just a couple of weeks ago. I was out with a friend who is born in the US, generations back in the US, and is very individualistic in the way that she expresses and perceives her own identity. My family immigrated from Latin America, and I have a very collectivistic understanding of who I am. So we met a stranger, and they were asking us, oh, who are you? What is it? Kind of what are you two about? And I said, oh, I'm so-and-so's daughter, and I have a brother and a sister, and I have 2 nephews, and I belong to this church community, and I live in this neighborhood. And my friend said, I'm an artist, and this is where I work, and these are things that I enjoy. These are my passions. And it was so striking to me to think about just the different ways in which we see ourselves, rather as a person or as a part of a whole. And this is really important when we start to think about trauma in terms of community impact, especially in these collectivistic cultures. So when we think, for example, about vicarious trauma, social context and connections are so important, because what's happening to a community in these cases is happening to an individual. And what's happened to an individual is in fact happening to their entire community. The lines here can look different. And when we're conceptualizing, it's really important to treat those lines as if they are different. Third, trauma is enacted. And it's enacted and it's reenacted. And when trauma is an everyday of a part of a community's lived experience, as is common in a lot of countries around the world, reenactments of generational pain doesn't just stop with migration. So being able to think about a person's history in terms of their family, in terms of their culture, in terms of their social group, and how that may impact behavior ongoing for years. And finally, trauma is extended. Experiences of trauma change how people think about themselves, they change how people think about the world, and they change how people think about suffering. And this is going to be directly impacted by culture. So perhaps my culture thinks that it's important that we suck it up and move on when something difficult has happened, maybe because we simply have to in order to keep putting food on the table, in order to keep moving forward. Maybe we think that we can't ask for help when difficult things are going on, or that when things are going on that are difficult, there's a specific person I need to seek help from, whether that's a child, a sibling, a parent, a religious leader. That person might not be your doctor. And maybe even is there beauty to be seen in this? I really love the way that trauma is conceptualized in Latin America, which is seen sort of as a direct translation would be pain, suffering for love. And being able to think about just how people see their experiences, how they make meaning of it, and how that's going to be directly impacted by language, by culture, and these broader cognitive structures that are going to shift and change is really important for how we understand an individual's experience. So with a framework of trauma just being a concept that is dipped and soaked in a cultural background. Let's talk about some practical approaches to trauma with international populations that we can consider implementing day to day. And I want to talk specifically about assessment, about conceptualization, and treatment. So the first piece here just being assessment and thinking about, are we asking the right questions, right? We work with a complexly traumatized population, and I think that we're all aware that trauma assessment, both in literature and in practice, has some real gaps. There are experiences that we hear from patients that don't fit on the questionnaire. And some of those ones, particularly with international populations, our queries can miss out on really common, important, and formative experiences. So instead of talking about trauma broadly or asking broadly about assault, which are terms that are so wrapped up in cultural context of what those things even mean, how can we ask more specific questions? And with regard to these specialized populations, what questions might be most relevant? Are we asking about natural disaster? Has this person dealt with famine, with flooding, with earthquakes or drought, violent conflict, with even abuse aside? Has there been political or gang violence locally? Has an individual been able to walk around their community safely? What about at night? Have they ever been robbed or held up at gunpoint? Have there been threats of violence? Is there intimidation from the government? Is there intimidation from paramilitary groups, from gangs? A lot of experiences that might not occur to us right off the bat. And finally, vicarious trauma, which is so huge, especially in these collectivistic cultures. Have any of these things happened to your family? Has any of this happened to your neighbors? Were stories about this kind of violence passed down generationally in your family? If you're a second-generation immigrant, how was it that your family came to live here? Why was it that they left where they were coming from? And being able to see, again, collectivistically, what happened to your community that you are now living out is going to give us a much better view of this individual's experience and perhaps their suffering. So taking the time just to get that better picture is going to set us up for better understanding and for better connection. Let's talk as well a little bit about conceptualization. Does our theory actually fit the populations that we work with? And the unfortunate spoiler alert is that it doesn't. Diagnostically, a whole multitude of models of trauma have been proposed, with the most popular one, of course, being the DSM-5 model of PTSD, which has 4 factors or 4 sets of criteria. And I want to not get super into the weeds here, but basically the idea here is that there are a lot of different concepts of what a trauma syndrome might actually be. Another popular model is a 3-factor model that was used in the DSM-4. I guess I should say that was an unpopular model because it was replaced in the DSM-5 because it didn't really map well onto the populations that people were seeing and serving. Other 4-factor models include the numbing and dysphoria models, which also just use 4 sets of symptom criteria but emphasize different symptoms. And when people are putting together a diagnostic manual, one of the things that they do is go to a population and start to map on our proposed model, our proposed theory of what a syndrome looks like, and say, does this fit people's experiences? And if it fits the experiences of the target population, then it's likely that that's going to be the model that we're going to use. So what you'll see here is a chart that outlines model fit by various regions of the world. Essentially, how do these models map onto or not map onto populations that are non-Western, low and middle income countries? In this chart, green is going to indicate a good model fit, yellow will indicate an adequate model fit, and red represents a lack of fit. So when we take our current diagnostic models to bat, what we see is that the one that we use isn't actually the best fit for a lot of non-Western or low and middle income countries. And maybe even more jarring, we can see that the best model fit is going to vary by region, with some regions, like parts of the Middle East, not being adequately captured by any proposed models of traumatic stress that we have out there right now. Similarly, when we're thinking about ICD diagnosis, and specifically the newer diagnosis of complex PTSD, which in some ways can be helpful to capture a broader look at people's experiences, we see the same cultural discrepancies, specifically with regard to that DSO, or differences in self-organization symptoms, which are just going to be similarly affected by cultural formation. Again, in a similar pattern, we know that trauma syndromes, which are diagnosed and colloquially understood in other countries, aren't typically seen in Western high-income countries. So significant mismatch in terms of how these things actually present practically. Rather than simply being different words for the same experiences, which is a really common misconception, these syndromes actually don't have sufficient overlap with DSM or ICD diagnoses to simply translate them from one to the other. In sub-Saharan Africa, we see kufungi sisa, which is a pattern of worry and rumination, hallucinations, insomnia, and chest pain following trauma. And to try and set that onto a DSM diagnosis, like maybe schizophrenia, like maybe PTSD, would be really difficult and a disservice to these patients, simply in its inaccuracy. In South America, susto literally means soul loss, and this can follow trauma as well. This looks like dysphoria, fearfulness, GI distress, and broad pain. There have actually been cases in which this has been deadly. In Burma and Indonesia, we see kyal, which are episodes following trauma that are characterized by tinnitus, vascular and circulatory issues, shortness of breath, and heart palpitations. And in Central America, we see ataques de nervios, which are bouts of dissociation, which are accompanied by anger, crying, trembling, heat in the head and chest following, again, experiences of trauma. And a common place that we can get to here is saying, oh, well, that sounds close enough to a panic attack. I guess I'll call this panic disorder. When in fact, we don't have sufficient enough diagnostic overlap to call that the same syndrome, and are starting to miss the mark really in our ability to capture accurately a patient's experience and then treat it in a way that's faithful as well. So responses can look so different in so many different places. And running through our DSM or our ICD checklist with folks from international origins is simply insufficient assessment. Looking into cultural syndromes related to a patient's background and assessing for related symptoms is good patient care, and it really needs to be part of regular practice. Finally, intervention. In terms of individual treatments, effective and acceptable choices are going to vary a lot by culture, but I just want to leave you with some guidelines that can point you broadly in the right direction. So when considering interventions, those that are designed transdiagnostically are going to be most ideal. Treatments that are designed for one specific diagnosis may not be a good match for folks whose experiences and symptoms look different. So rather than treating, say, a diagnosis of panic disorder, thinking about how am I going to treat sweating, trembling, shortness of breath, and fear? How can I treat these individual symptoms rather than a syndrome? A great example here is cognitive processing therapy for PTSD, which is a really, really useful treatment for PTSD as it's conceptualized in the US, which is as a disorder that's maintained by avoidance. In contrast, though, traumatic stress disorders in other countries often don't involve an avoidant component. And so using cognitive processing therapy in those kinds of cases is not useful because that symptom that's the target isn't one that's really prevalent. Secondly, you want your treatments to be adaptable. The more that you can flex a treatment, the more acceptable it may be to the patients that you serve. Some highly adaptable interventions include things like behavioral activation, problem-solving training, coping skill training, and interpersonal therapies. So any space in which you can really modify your approach and adjust according to a patient's experiences and preferences are going to be your best fit. And finally, we want to be relational. And this is the absolute best news for providers who are trying to do culturally responsive care that's trauma-informed and to do that well. Because all the evidence that we know about relationship and rapport being the foundations for effective treatment hold true for international populations. So by building trust, communicating openly, collaborating, and seeking to see and know people as culturally embedded beings, we can offer care that really, really makes a difference. So I want to thank you so much for your time, for your attention. I want to leave some space for questions, and because we're all presumably a little bit nerdy in this space, I also put up some questions of my own if you'd like to engage with discussion in that way.
Thank you.
Yeah.
Well said and presented. As you were talking about this, I tend to think about a population here in the hospital. We get We're talking at least 50% of our hospital population is ICST.
Mm-hmm.
May or may not be from culture outside the United States.
Yeah.
One of the things that comes up with some of these patients is our medical staff uses the term malingering.
Mm-hmm.
Well, we think they're malingering. We can't find anything wrong. They just want to get out of jail.
Okay.
And I am wondering from your presentation, it's just an open thought and idea, question about how trauma and the individual's culture is affecting their response. Because jail's a horrible, nasty place, and people respond to it in various ways. Doesn't mean they're not actually still presenting a real need of pain. So, what would you think, how would you think that cultural care might apply to a situation like that, where they may not be malingering, it just may not be showing up, as you said, in some model that we understand?
Right, and that creates a really complicated situation for us as providers who want to respond compassionately in care and are also working with the constraints of a pretty complicated legal system in which sometimes we don't have a lot of control, right? I think that you bring up a really great point, that the symptom presentation looking different sometimes can lead us to say, there's not a problem here, there's not suffering here, in which case we're really frequently missing the mark. Because I think our understanding even of an individual who has found themselves incarcerated ought to be, what exactly happened to this person, that they landed at this place in their life, that their pattern of behavior looks like this, that their pattern of relationships looks like this. And I think so frequently the answer that we're going to find, is trauma. And then the question becomes in terms of how care proceeds and how legally we proceed. Is this person actually competent to stand trial, which is a different question than is this person suffering, because there are plenty of suffering people, unfortunately, who are competent to stand trial. And being able to parse those two things out, certainly considering cultural formation in terms of how a person's symptoms are expressed, what that looks like diagnostically, how we're going to go about treating that, and also being able to keep in mind the constraints of, unfortunately, within this system, suffering not always being sufficient impetus for care through this specific agency, but rather thinking about how can we be referring to care in this person's next steps, whatever that might look like. Is that, helpful? Great.
Did you find anything in your research regarding like acculturation and assimilation? Because I'm just thinking about in terms of kind of people's level of integration into American culture. I mean, obviously I work with the youth patients, so a lot of times we'll see, their perception is very different than their parents or their grandparents, and kind of dealing with that difference on top of all these other things.
Yeah, absolutely. And that impacts things at multiple levels. And one of the most interesting ways that we see that come out is actually symptom expression. Folks from international backgrounds who are still living overseas tend to have lower levels of mental illness than we see in the U.S. When people immigrate to the U.S. as adults, we see those numbers basically holding steady, that they'll be more consistent with the country of origin. However, second-generation immigrants, essentially the children of immigrants, or individuals who immigrate as children, are going to experience levels of mental illness that's more consistent with the local native-born population. So certainly differences in terms of an individual's acculturation, in terms of how their suffering is expressed, how it's experienced, and then in terms of how we start to respond to that as well. Because second-generation immigrants are also going to be a lot more likely to seek out care, frequently due to those cultural differences and levels of stigma. Yeah.
I have a comment here
Lovely.
from Lana? I think the concepts of this presentation are important to consider and apply to all individuals, given family backgrounds are all different, even if they are native born. So this is very useful, even beyond the intent of the presentation. Thank you.
Yeah, that's a really, really great point. And I appreciate that comment because I think that one of the issues that we can face in culturally responsive care is saying, okay, how is this person different from us? How is this person different from what's normal? Which backs us into a really strange corner of having to figure out who exactly is normal and why that person is the normal one. So instead, being able to recognize each individual as a culturally embedded person, especially as we're considering intersectionality of identity, not just where a person is from in the world or where their family is from in the world, but all the other pieces that make up who we are, enable us, to be able to execute better patient care for everyone. That's a great point. All right. Well, and with that, I'll say thank you so much for your time. To those who tuned in online, thank you. I really appreciate it. And I hope that you enjoy the rest of your lunch and are able to finish it out well.